and Dr. Rutula. And she has completed her MD in palliative medicine from Tata Memorial Hospital. Now she is working as an associate professor in palliative care from in Bharati Hospital. Over to you, doctor.
Thank you so much for the kind introduction. Hi, everyone. I'm Dr. Rutula. As ma'am said, I've done my MD in palliative medicine from Tata Memorial Hospital, and I'm currently working in Bharati Hospital in Pune. So we'll be briefly talking about palliative medicine and non-oncology conditions. As we know that majority of the palliative care that is currently provided is concentrated in oncology patients, but a vast number of patients that we have are from non-oncology. Am I clearly audible? I apologize for two things. I'm sitting outside actually because of some range issue. So there'll be a kind of...
Yes, you are audible, clear.
All right. Thank you so much. Okay, so we'll keep this as an interactive sessions. Feel free to ask any queries or doubts that you might have in the middle. And please join in, pitch in for all the questions that are raised. So can anyone just tell me what do you understand by palliative medicine or palliative care in general? And not the accurate definition, I mean just your perception of what palliative medicine should be. Anyone? Anyone just unmute and just say whatever comes to your head.
Hello, ma'am.
Yeah, please go ahead.
Good evening, ma'am.
Good evening.
It's like not just about the pain. We should consider the psychosocial all factors so that we can give the quality of life of the patient can be improved.
Okay, very good. That's an excellent point. So in the chat, we have end of life support, improving quality of life, as you correctly said. Supportive treatment, including counseling as well. Correct. So that's what it encompasses.
It is an approach that improves the quality of patient and their families facing the problem associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment.
Right, exactly.
And treatment of pain.
Right, exactly. So next slide, please. So as you correctly said, the definition by WHO says that it is an approach which improves the quality of life of patients and their family members who are facing the problems associated with life-limiting illnesses. So, and as you all correctly said, that it is not just physical symptoms, it is psychological as well, social and spiritual as well. Next slide, please. So coming to the whole process of palliative medicine or supportive care, initially at the beginning of when palliative medicine was at its very infant stage, they would do it only during the end of life or at end of life situations. But over the past few years or decade, you can say it has been shown a tremendous improvement, and it goes on from the time of diagnosis of a life-threatening illness, that is at diagnosis of, let's say, cancer, or mostly in cancer. It's not been applied to all the illnesses as of now. So at the beginning of, at the time of diagnosis or as soon as possible, and then it goes on till end of life, and post that for bereavement support. So during the phase where it is, as you can see, from acute to advanced life threatening, during that time, it might not be that palliative care or palliative medicine physician have to be there continuously. They might just come and go as and when required by the patients. Sometimes our needs, like their palliative care needs might be more compared to the need for disease modifying therapy. And sometimes our role takes a back foot. Next slide, please. Again. So again, to just emphasize that palliative care goes hand in hand with disease modifying treatment or disease management, and that it is a bow tie model which is kind of integrated into each other. Next slide, please. So I'm just brushing through this because this is something that we should know about palliative medicine and supportive care. So there are a few competencies that we as palliative medicine physicians should have. So basically, we should be able to describe what a palliative approach of care is, what it entails, and what it means to get the said care. Then we should be able to address all the symptoms, especially pain, because it is one of the most commonest and most distressing symptoms that the patient suffer through. They should be able to address and manage it well by knowing how to get a thorough history, what physical examination would be appropriate for the said symptom or for the said patient, and if required, any relevant investigations which are necessary for proper management of the symptom. Next slide. Then we should be able to participate in the proper care of a dying patient and also their family members. So we should be able to identify what the signs of approaching death are, what are the possible signs and symptoms that we can expect during the natural dying process. And also we should be able to prepare and educate the patient as well, but more importantly the family and the caregiver when the death is nearing. And also we should be able to take proper care of the body after that death. So this is what is called as after death care of the patient. Next slide, please. Then, as you've already correctly said, that we should be able to assess the psychosocial needs and the spiritual needs of the patient. There are various screening and assessing tools for both of these, and which I'm sure you'll learn as you go ahead. And we should know how to use these tools and how to approach or to manage the psychosocial needs and the spiritual needs of the patients or the caregivers. Then end of life decision making is a very important part of palliative medicine. So we should be able to approach the end of life care decision making and planning for the patient and the family members using the ethical frameworks that is available at your institute or in your state or district, because it varies from place to place. So we should be able to do that. Next slide, please. Then communication forms a very important aspect of palliative medicine. You can say that it is a backbone of palliative medicine. So we should be able to communicate effectively and as empathetically and gently as possible with the patients and the families, and get through to them as to what is important for the patient and their families. Then we should always remember that all the symptoms and all the possible problems that the patient or the family members are having are always multidimensional. So it is never on the face value, as you say. It always has some other adding or exacerbating factor to it. So we should always keep that in mind and approach the symptom or any problems as though it has multiple reasons. Next slide, please. And along with the patient care and the family care and the caregiver care that we provide, we should be able to give the same amount of importance to ourselves as well. And we should be self-aware and as to when we are going towards a burnout and where we are having certain the kind of like, sometimes it gets too much, especially when you're dealing with end of life decisions or end of life situations very often. So sometimes you might need a break, and that is absolutely fine and normal. So that should be kind of encouraged if required, because if you're not your 100%, you won't be able to give your 100% to the patient and their families. So these are just the few competencies that we as palliative care physicians require and should have. Um, and so basically to manage the patient better. Next slide, please. So I'm sure you all know this, the 4 roads to death, as we call it. So everyone would want a sudden death. That is the graph A here. Everyone would want that, but not everyone has it. Like, most of them never have these kind of sudden deaths. Terminal illness is, as we said, oncology or uh, oncology, basically oncology or any chronic illness which does not have a lot of exacerbations in hospitalizations. So basically it because of the life or the disease modifying agents, the patient is fairly okay for a long time and then has a gradual deterioration leading to the death of the patient. Then organ failures is your respiratory failure, your cardiac failure, your liver failure, etc. So basically there is a lot of deterioration with hospitalization which come back to normal, but not as normal as it was before the diagnosis of the patient. So every hospitalization or every deteriorating episode during the course of the illness takes the health in a downward spin. So basically it just goes down, and suddenly once at the last admission, the patient might not recover from the exacerbated state. And the last one is frailty, that is old age or aging, normal aging process, where the whole functionality of the patient is down, and it goes further down and leading to a natural death. Next slide, please. So as I said before, mostly we have, as palliative care physicians, dealt with only advanced cancers till now, because that is where it has been widely accepted, and uh, we have a lot of experience in that. But uh, like it is likely to be benefited by patients with organ failures, neurodegenerative illnesses, advanced rheumatological diseases, even ICU care. For example, patients who have been in the ICU for a prolonged time and are having multi-organ failures and are not responding to the treatments that have been given. Next slide, please. So what do you think are the likely barriers that prevent the physicians from referring patients to palliative care? I'm not talking about oncology, I'm talking about non-oncology scenarios. Can anyone just, next slide, please. Can anyone just, just unmute and then just say what it might be. Next slide, one more. Yeah, so so let's just divide it into physician's perspective and caregiver perspective. So what do you think it is, what are the barriers from the physician's point of view that prevent them from referring patients to us?
Actually, in a wide, can I answer?
Yeah, sure, please go
Yes.
ahead.
Actually, in a wide land area of the region, there are places where palliative care is not available. So, physician try to give whatever treatment is possible for the patient.
Okay.
And even it is very difficult to convince the relatives that now the treatment from physician side is only this much we can be given, and we can suggest you to take and take the palliative care. But even the relatives don't know where the palliative care will be available in most of the village area or the rural area or the different types of regions of India.
Right, correct. So it is basically the lack of facilities for providing palliative care. As Ajila has very rightly pointed out, physicians are focused more on cure rather than letting go. So that is an excellent point. Any other points that you might have?
Can I answer,
Yeah.
madam?
Sure, please go ahead.
Physicians, they may be having busy in their seeing the patients, number of patients, or in their time, sparing time like that. So they may not be able to go through all the social aspects, psychological, and all these aspects. But
Right.
palliative care person can take care of all these things. That is
Excellent point. Yes. Yes, it is that, it is not the terminal stage at the moment. So yes, that can be one reason.
Hello, ma'am.
Exactly right. That lack of awareness. Yes, please go ahead.
It may be because of the misbelief that the palliative care is only for the cancer patients.
Yes, yes, that is an excellent point. Yes, that is true. Can next slide, next, just till the end of the slide, couple of more. Yeah, I think that's previous one. Sorry. Yeah. So as you rightly said, it is cure always from the physician's point of view, because they don't want to let go, as you correctly said. And referring to palliative care would be like giving up on their patients, which they don't like the feeling. They don't realize that we'll be helping them instead of them giving up on the patients. They take it as a personal failure. So like they couldn't give their 100% to the patient, so they take it as a personal failure. And as you've correctly said, that there is lack of knowledge in general amongst all the physicians about what palliative medicine and what supportive care is. So yeah, so from physician's perspective, this is what it is. Next slide, please. So yeah, so from caregiver's perspective, can anyone tell me, like, put yourself in their shoes, and what would be the reasons why you would not want to go to a palliative care OPD or palliative care physician?
Again, the same thing, they would feel, the caregiver would feel that this is not the terminal stage, and
Right.
the palliative care is only for the terminal stage. That's what they think.
Yes.
So lack
correct.
of awareness is again the part.
Yeah. Anything else?
lack of awareness that it improves the quality of care, and they can be taken up in a good functional status.
Right. Right. It's lack of knowledge about palliative care and lack of awareness and apprehension that it's only for the dying. Yes. Anything else?
One more thing is we have to also look about the financial support, because
Yeah.
most of the time, if the patient is for a very long time in the ICU, it is very difficult for the relatives and the caregivers to have a financial support for a very long time.
Yeah. Yeah. That is true. Don't want to quit. Yes, this is an important one. Refusal to come to terms with reality. Yes. They would like to exhaust all the curative options, as if at all any. Right. Correct. Can you come till the end of the slide, please? I think there are four. One more. Yeah. Thanks. So as you correctly said, the disease trajectory is so vague. As we saw, it's just waxing and waning of all the symptoms, and there is exacerbation and control with few hospital admissions. So it's difficult to pinpoint which will be the last hospital admission and when they will deteriorate to a point where it's no longer feasible for them to go back home. So the disease trajectory is kind of very confusing and unpredictable. They want everything to be done for the loved ones. They don't want to give up on the patients, and they kind of, because of this, they might have some amount of guilt that they can have. So they don't want to give up on their patients. And then, as especially in our country, it's like, what will people say? Like, how could we not do anything for the patient, and how could you not take them to the patient who to the doctor who could cure them and make them better? So what society says also plays an important role, especially in our country. Next slide, please. So coming to the non-oncology diseases where palliative care might benefit the patient. So from central nervous system diseases, it's the dementia, the Parkinson diseases, the traumatic brain injuries, and the stroke. So what I'm going to do is I'm going to briefly point out the few common symptoms that these patients have and then how to manage it. I'm not going into the detail of all the diseases and what's specific to what diseases. So it's just a common list of symptoms that they might present with and how we deal with that. Next slide, please. So common CNS symptoms are seizures, your aplasias or paresis, that is hemipara or quadriplasias or paresis. You have your dystonias, that is hypertonia or hypotonia. You'll have dysphagia and apasias, which are quite distressing to the patient. Next slide, please. So coming to the management, rehabilitative measures all across the board. So not only for central nervous system diseases, but all across, for respiratory, for hepatobiliary, for kidneys, everywhere. It goes across the board. So wherever possible, give any and all rehabilitative measures that you can, because they go a long way in dealing with the symptoms. For hypertonia, especially, muscle relaxants would help. Baclofen, especially because it's a centrally acting muscle relaxant, so that would help way better than the rest of them. So free use of muscle relaxants as and when required. Analgesia, because it might not only be the muscle spasm that the patient is having, they might have some other kind of pain as well. So analgesics and opioid analgesics are helpful and should be given liberally. Though in a monitored dose, I'm not saying just give it indiscriminately, as when and how much the patient requires, but they should be made available for these patients as well, and it's not just used in oncology. Anti-epileptics, because seizures are an important symptom, and also anti-epileptics will help with neuropathic pain as well, so they should be used whenever required. And as we said, the patient might have swallowing difficulties or dysphagias or odynophagia, and sometimes might lead to aspiration pneumonia as well. So wherever needed, an nasogastric tube or a gastrostomy uh, should be made available for the patient. There is always a question of whether nasogastric tube is more feasible or a gastrostomy tube is more feasible. That is up to you, I guess. There is not a lot of difference, especially when it comes to the end of life situation or during when the patient is near to end of life. But if it's a long-term use of the said feeding tubes, then a gastrostomy is, the research says that gastrostomy is preferred, because it prevents aspiration, because your lower esophageal gastroesophageal junction, like sphincter, is closed. If you put in a nasogastric tube, it remains open and the chances of aspiration is there even if the tube is in place. So, but again, if it's not feasible, because peg insertion is an expensive procedure and not all patients or relatives might have the source of fundings required for the said procedure. Speech aids, especially in aphasias, are important. So you have a lot of electronic or laser driven speech aids, but I'm not sure if they are available everywhere, or they might be available in cities especially, but not everywhere. So we'll need to kind of, the simplest one would be, asking them yes or no questions, so that they can just, maybe they can blink or move their eyes once if it's a yes, or twice if it's a no, something like that, just to make it easier. But there are a lot of aids that are available, but we'll need to find out if it's available in the area that you practice in. So there's a question in the chat: who all are included in a palliative care team? So ideally, it ranges from your physician, your nurse, your social worker, your psychologist, your counselors, chaplains, or any religious heads if they are available, your physiotherapist, your uh, occupational therapist, everyone. It covers everyone so that we can actually provide the right type of care for the patient. Next slide, please. Coming to the cardiovascular diseases, so main diseases that we look at are the heart failure, your congenital heart diseases with or without isomerization. Next slide, please. So the common symptoms here are generally your breathlessness, chest pain or heaviness that the patients feel. You have a lot of palpitations, which they describe as racing of the heart, which lead to a feeling of anxiety. There's a lot of peripheral edema, cough, which might or might not be irritant and dry, with or without hemoptysis. So that is another history that we need to elicit from them. There's a lot of fatigue and sleep disturbances. Next slide, please. Again, as I said, rehabilitative measures all across the board. So wherever possible, you give all and whatever rehabilitative measures you can give to the patient. Opioids here play an important role, not only for pain or the chest heaviness that they have, or the body ache that they might be having, but also for the breathlessness that plays a very important role, and it might just improve their overall quality of life, and also might have some survival benefit as well. Diuretics, yes, it is important because it reduces the preload as well, and the peripheral edema, which kind of improves their overall functionality and symptoms as well. Beta blockers is kind of a controversial point, like it might or might not help. So if required, if the palpitations are too much and if the overall feeling of anxiety is too much, a low dose beta blocker might be given, but we'll have to kind of weigh in the pros and cons of giving beta blocker. Oxygen support, whenever required, yes. So it might be necessary, especially if the saturation is dropping. If not, it should be used very judiciously, because that's a medicine, so it should be used as a medicine. It should not be just because the patient is feeling breathless you give oxygen therapy. There are a few non-pharmacological measures for breathlessness, especially if the saturation is maintained at least around 90, if not, and it's not dropping below 85. And can anyone just tell me what are the non-pharmacological measures for breathlessness? Have you guys covered the topic of breathlessness in the
It's a propped up position.
Yeah, correct.
Then keep the ventilation of the room proper. See to it the patient is near the window so that the ventilation is proper.
Correct. Anything else?
Second
Then
method,
give assurance to the patient, talk to the patient that relax, we are there with you. Most of the time breathlessness could be because of anxiety.
Okay.
One component could be because of anxiety. What will happen? So we have to talk to the patient.
Right.
Give
Yeah,
assurance.
Breathing exercises.
Breathing exercises, yes. Spirometer, chest physio, using a fan, pursed lip breathing, correct.
And then immediately see for SpO2 level with the pulse oximeter. And if the oxygen level is okay, then you need not worry.
Right, correct. Head and hand elevation, proper position, cold food. Cold food, especially for nausea, vomiting, not so much for breathlessness, but that's a good point. Cool air in the room, that helps. So if it's hot and humid, they feel more breathless. So if you can just maintain, if you have like air conditioners or something like that, then that actually helps. Like, just having a not cold, just a cool room temperature will help with uh, the breathlessness. And using a fan, what she meant was a handheld fan, with air directly on the face. So the receptors on the face kind of help with managing the breathlessness. So excellent. Thank you so much. Next slide, please. Yes, not doing exertional work and avoiding worries and tensions. Correct. So respiratory diseases, that is end stage COPD, end stage ILD, you have your cor pulmonale and pulmonary embolism. Next slide, please. So the symptoms overlap with that of cardiovascular. So, but some might be more than that in cardiovascular. So we need to kind of differentiate between that. Breathlessness, weight loss, fatigue, delirium, palpitations, and headache. These are the commonest symptoms that you'll see in respiratory diseases. Next slide, please. So again, rehabilitative measures, as you've all correctly said. So those and non-pharmacological measures should be given to the patients. Opioids, especially for breathlessness, would go a long way here. Diuretics, again, if it is, pulmonary edema is there, or sometimes, they say even furosemide nebulization has seen to have some benefit in breathlessness. But again, it varies from patient to patient. And acetylcysteine, especially with patients who have a lot of mucoid secretions, they might just help it loosen it a bit, and with the help of chest physiotherapy to clear out the airways so that breathing becomes a bit easier. Then oxygen support here might be necessary because your saturation keeps on dropping. So here it might become more beneficial. If the patient lands up with delirium, hallucinations, we might need to use antipsychotics as and when needed, and steroids. So most of the time steroids are a part of their disease modifying treatment that they have during the curative phase. So they might just be continued, or it might be added as an extra during the course of the exacerbation of the disease. Next slide, please. Coming to the hepatobiliary diseases. So mostly the most common diseases that we deal with are your liver cirrhosis and liver failure. So can anyone tell me what are the common symptoms that you will expect in these patients?
Good evening, ma'am. One is hyponatremia.
Yes, okay. Dyselectrolemia, anorexia, ascites, jaundice, fatigue, nausea, vomiting. Correct. Next slide, please. Amazing. So as you've all said it exactly. So basically signs of liver failure, those are all your ascites, jaundice, hepatorenal syndromes, and bleeding, and altered sleep cycle, and fatigue, weight loss, nausea, vomiting. Excellent. Pruritus, yes. Constipation. Yeah. Next slide, please. So can anyone tell me, since nausea, vomiting is one of the major side effects, major symptoms, major symptoms. So what would be your ideal drug of choice here for nausea, vomiting, and the reason behind it? Anyone? What would you give to a patient with, let's say, liver failure? He's having a lot of nausea and vomiting. What would be your drug of choice? Perinom, okay. Domperidone, okay. Peripherally acting. Okay, so what do you think is the reason for the nausea and vomiting here? What is causing?
Ascites.
Okay. Anything else? What?
Mercaptans.
Sorry?
Mercaptans.
Mercaptans, okay. Raised belly, right. So it's on them, yes. So you basically it's the raised belly and mercaptan, as you said, it's basically centrally acting. So you need a medicine that is centrally acting, which would help better. So perinorm would help, but then again, you have the risk of developing extrapyramidal side effects. So you do not want to do that. So ondem will be a preferred choice. Pan, domperidone, okay, maybe. Like, so again, domperidone is not centrally acting. So the preferred choice would be your ondansetron.
Onden.
Yeah, so that will be, or haloperidol for that matter. Haloperidol works wonders in patients with liver failure. Right, correct. Pruritus, someone said pruritus. So what would be, they have written here already. So sertraline becomes the first choice, first line drug for pruritus here. And it works wonders. I've personally given it and seen the results. So it works wonders for liver failure associated pruritus. For laxative, what would you give as a laxative here?
We
Lactil.
can
Yeah, go ahead. I'm sorry.
we can give Dufalac or Crimafene.
Clemafin. Okay. Why lactulose per se? Dufalac, as you said. Why lactulose? What is the reason behind giving lactulose?
To prevent encephalopathy.
Why? How does it prevent encephalopathy?
Um,
One thing we've missed out in antiemetics is that the ammonia levels, the blood ammonia levels also increase. So that is another reason for the nausea vomiting. And again, here for encephalopathy is the raised ammonia that is causing. So basically ammonia
Yes,
produced.
yes.
Yes, bacteria basically washes off the bacteria. So lactulose is preferred. And as I said, supportive measures. So basically, if the patient has gross ascites and is feeling breathless because of that, then you kind of do ascitic tapping to relieve the symptom. And all those such things, oxygen if required, ascitic tapping if required, and any other supportive measures that you can give to the patient as and when required. Yes, correct. Intestinal production and absorption of ammonia. Next slide, please. So coming to renal diseases, basically it is the end stage kidney diseases, which is secondary to either hypertension, diabetes, or glomerulonephritis. Next slide, please. Symptoms are your nausea, vomiting, decreased appetite, fatigue, decreased urine output, your signs of fluid overload, which comes out to be edema, chest pain, breathlessness, headache, and increased blood pressure. Pruritus, again, you have your muscle twitches and muscle cramps and sleep disturbances. Next slide, please. So again, what will be the antiemetic of choice here? Anyone?
Ondansetron.
Yes, correct. Again, centrally acting, as you rightly said, any centrally acting would do. So what is the reason here? What is the cause of nausea, vomiting here? Uremia, exactly. Excellent.
Azotemia.
Yes, exactly.
Yeah.
Excellent. What, any thoughts on antipruritic agents? So here it comes out to, your local capsaicin or your UVB light would help better than sertraline here. Sertraline comes as a third line agent. Here it's local application of capsaicin and your UVB light therapy. So those are your first line agents. And your pregabalin, gabapentinoids would come in second. Again, laxative is again your lactulose basically. Any supportive measures? Any that you can think of? Specifically for renal management.
Low salt diet, restricted fluid intake.
Yes, correct. Diuretics, yes, may or may not, depends on what the urine output is. So again, we'll have to kind of manage that. Yes, excellent. Next slide, please. Because breathlessness can occur in almost all the diseases that we have, we need. I just wanted to kind of specify the breathing, thinking, functioning model for breathlessness. So basically, it encompasses everything that the patient might feel during the said episode of breathlessness. So the breathing here usually means that there is ineffective breathing, so that there is some problem with the actual whole mechanism of breathing. There is some sort of like small airway obstruction or something that is wrong with your breathing whole anatomy there. Then basically what happens, or there is increased work for breathing. So what happens is basically your respiratory rate increases, and there is use of your axillary muscles, and there might be hyperinflation of the lung. In thinking, what it basically encompasses is that your because of the stress due to your illness, or any misconception that you might be dying, or your some misconceptions about the the distress that is associated, or the increased amount of and severity of the symptoms that we might have during the end of life process, then a lot of excessive attention to the sensations that are happening right now, and past experience and memories also add into the thoughts that we have about the said breathlessness, which lead to kind of an anxiety, distress, and panicky feeling, which increases the breathlessness. And functioning encompasses where, because of the reduced use and activity of the said muscles, and self-isolating in one room, not moving around, and dependency on others, lead to deconditioning of the muscles and the limbs and the chest wall. So basically leads to more breathlessness. So there are a few things that we can do at each step, at the breathing part of it, the thinking part of it, and the functioning part of it, to kind of help overcome breathlessness or help manage it better, if not to completely subside. So this is kind of important. I'm sure you can just take this up and kind of use it while managing breathlessness. Next slide, please. Coming to end of life care, because it is important and kind of tricky, especially in non-oncology patients. Just to kind of briefly highlight how we do it here in the institute. Next slide, please. So this is basically given by the Indian Society of Critical Care Medicine, and as you can see, it's quite confusing. So kind of this was specially for patients who are in the ICU, and a consensus is made to come to the option of end of life care for the patient. So next slide, please. So this is what I have done to kind of simplify the process, if not make it absolutely as per what was given by the ISCCM. So basically, the patients might be referred either from the emergency department or the casualty, or they will be referred from the ICUs, the wards, or your private rooms, or the patient and the relatives might know about palliative medicine and they themselves come into your OPD. Because there is a prognostic uncertainty, especially with the primary physician's assessment. So another physician who is not directly involved in the care of the patient is involved. and there comes a consensus between both of them or all of them, whoever, how many ever are involved, to make, to assess for futility of further life, further disease modifying treatment. So if it is, or life sustaining treatment also for that matter. So there should be a consensus amongst all the physicians that are present, that continuing the life supporting or life sustaining treatment, or any life disease modifying treatment for this patient is of no further use. So when once this consensus is achieved, we should have an honest discussion about the prognosis and about the said plan with the relatives, and we should establish the goals of care for patients. So once all this is done, and we have a consensus even amongst the family members and the patient and all the possible relatives of the patients, then we can make the life withholding or withdrawing of life sustaining treatment, or give a time limited trial, or shift to ward on palliative care only, or maybe continue the life disease modifying treatment for a particular amount of time, and then again reevaluate the patient, and then we provide effective comfort care, as we call it in our hospital, for the patient, and support for the family. And it is important to document everything as we go through the process, and it is important to know that it is not set in stone, that the relatives or the patient himself or herself has every right to change the decisions he has taken previously, and to revisit it as and when required. Next slide, please. So we have a long way ahead, a long road ahead, especially when it comes to non-oncology palliative medicine. This was just a brief and introductory session, I would say. If you have any thoughts, doubts, questions, or any comments, please feel free. Thank you.
I want to just tell that most of the time the patient does not want to die in ICU. And patient wants that he wants to be with the family members and be at home during the end of life. But the physicians say that you require life supportive measure and you be in the ICU, and if you want to go home, you have to take discharge against medical advice and go home.
The thing is, since I am actually based in ICU, because I come under critical care medicine where I work at the moment, sometimes it's not possible to withdraw the patient from the said ventilator or from NIV, let's say, or anything that is maintaining, that is life sustaining. And so you need to be kind of clear as to what will happen once you remove the said ventilator. They might not even survive the amount of time it is required to go from the hospital to the house once you remove that measures, right? So you need to make that clear to the patient and the relatives that this is what is going to happen, even if they want to die at home, which I completely understand and would want that for the patient. It might not be feasible just because they've been on a ventilator for, let's say, 15 days, 20 days, and they cannot be weaned off from it. So you need to kind of make it very clear. And that's why the doctors also say that you have to take discharge against medical advice, or whatever, Dama Lama as they call it. So it's quite understandable from the doctor's perspective as well. What you can advise them is that it is terminal discharge. That is what we do here at Bharati. We call it terminal discharge when this sort of thing happens. So it is not discharge against medical advice anymore. It is terminal discharge, where the relatives and the caregivers are all aware of what is going to happen once we remove the life-sustaining supports that they are on, and that the patient might die in the hospital, but it is quite pain-free or distress-free. I hope that clears out what you had in mind.
Is there any special kind of consent that is required from the relatives?
So we have a comfort care form that we kind of document what the patient's current situation is and what the disease is and all the demographics. Obviously, if the patient is able to comprehend and able to sign it, then we take his signature. If not, then they have assigned first degree, second degree relatives who give the consent for all the procedures. Then we take their signatures and 2-3 relative signature, including the first degree one. And we have end of life care committee. So there is the head of critical care department, our deputy medical director, and the nursing superintendent who sign it at the second level. So there's a consensus among all. The treating physician as well have to sign in the comfort care form. So it's quite
Yeah, it's
well
a little,
documented as
yeah.
yeah.
It's a little, yeah, okay. And another thing, is it okay to stop the ongoing treatment, or is it just like no escalation of treatment?
So that varies from place to place and from physician to physician. If you're comfortable with stopping the treatment, when you know that the patient might not survive the said stopping of the treatment, then that's fine. Some physicians are not comfortable. Some will say that, okay, this is the baseline that we are going for now, and we will not escalate it further. So whatever happens, happens. We will not resuscitate the patient back. We will not give cardioversions. We will not do CPR, will not do anything. Whatever happens, happens at this level. Also, it also depends on what your institute allows. So sometimes it might not allow you discontinuing the treatment. So again, consent is important throughout all both of these decisions.
You mean to say the protocols vary according to the
Region and institutes, so supposing I say particular to Pune, so it might vary from Bharati to Ruby to Sasun Hospital, let's say, for example, so it varies from place, institute to institute as well. So what might be true for, let's say you're from Mumbai, right? So what might be true for Tata might not be true for, let's say, Hinduja, right? So even if it's the same region, it might vary from hospital to hospital.
Madam, suppose if the patient is under palliative care, suddenly if the relatives come and ask, no, now you please shift to ICU. Is it possible? Because we don't have ICU set up in palliative care. What to do at that time?
Shift to ICU meaning what do they exactly want from after shifting to the ICU? That should be clear. So their goals of care should be clear. If they do not, if they want to go aggressive, then that is their call and that is their wish. So you will have to do that. You cannot go against their consent anyways. So if they want to go all aggressive and put them on ventilator, put them on inotrope supports, put them on dialysis, for example, then that is their call and that is okay. And we can do that. And if they, especially with the people who are financially all right and affordable, they will want to do all these things. So they might have to, yeah.
My point is, we don't have ICU setup now, madam, when we are maintaining in palliative care. At that time, is it fair to shift to the place where they are having ICU?
And that's what exactly. So if that is what the patient or the relatives want, they can do that. But then again, you'll have to explore as to what exactly is their goal after being shifted to said ICU or any other tertiary center where ICU is available. If they want complete cure of the patient, that might not be possible. So you will have to kind of re-explore it, re-counsel the patient, re-evaluate what their goals of care are, And if according to their goals of care at the moment, with the consensus among all the primary decision makers in the family, if that is what they want, then they should be allowed to do that.
Okay.
Thank you, Dr. Rutula. Actually, this is one of the vast topic, but doctor has covered all the systems separately with almost all the common symptoms and its management. Thank you, doctor.
Thank you.
And I know you all have lots of doubts since we confront lots of non-cancer illness in our day-to-day practice. And we will see respiratory system and gastrointestinal system separately. And we will have another session on end-of-life care as well. So most of your doubts will be cleared on that session. Okay. And any other doubts you can just put up in the chat. After the case discussion, we will move on to that. Today, Dr. Nim is with us from Indonesia for case presentation. Over to you, doctor.
Hello, good evening. Am I audible?
Yes, yes. Yes, doctor,
all
you
right?
are audible.
All right. Thank you. Thank you so much for the opportunity, everyone. Good evening. My name is Yudia. I came from Indonesia, Bali, from Indonesia Red Cross. So today I'm going to do a case presentation for my patient. He's 71, male, with right hemiparesis, post-ischemic stroke, with grade 2 pressure sore on sacral region and COPD. So the presenting complaint, he has weakness on his right side and pressure sore on sacral region. He had sleep disturbance for the past month due to tingling pain on his right side. And he also sometimes get up at night because of persistent cough and shortness of breath. He also have loss of appetite and constipation for the past 2 weeks. And history of illness. So he was admitted to the neurological ward through the ER with hypertension, right side weakness, a hemifacial palsy, dysphagia, and he was diagnosed with ischemic stroke in January. And he got treatment for 2 months. And while in hospital, he was infected with COVID, which worsened his COPD. And he had to move to ICU for a week. And after that, he stopped doing his physical rehabilitation after 2 sessions because of the lack of funding. And after 2 months, he developed a bed sore and started to feel tingling pain, mostly on his right side. And he often wake up at night due to shortness of breath. And he also had decrease of appetite and constipation. Right now, he is only at home care because he doesn't want to stay in hospital. So for the present examination, he looked weak and cyanosis. Temp is 98 Fahrenheit, pulse 69. Blood pressure is 150 per 90, and respiratory is 24. For the cardiology is within normal limit. There's a wheeze with and without the aid of stethoscope. And also for the neurologic, the most problem he had is swallowing problem. And there is a sign of muscle atrophy on his right arm and leg. There's also motor and sensory deficit, and the power on the upper right side is 2, and the lower right side is 3, and on the left side is 5 per 5. There's also pressure sore. There's some exudate and intact blister present, and it looks irregular in shape. And for the treatment and significant investigation, brain CT without contrast, there is ischemic infarct on left corner radiata, and on chest X-ray, there is infected bronchiectasis. For the psychosocial aspect, he is retired civil servant. He lived by himself. His wife passed away 4 years ago. He have 2 kids, both of them married and living separately. They come once or twice a day, only for a few hours. His main income is his pension and some from his children. He had to take a loan to pay for the ICU fee, and the nearest hospital is 15 kilometers away. And right now he feels exhausted and fed up with all the medication, and he doesn't take his medicine regularly. Sometimes he feels useless because he needs to help to go everywhere, including to go to the bathroom. He is a heavy smoker, and his children limit his cigarette intake, and that's one of the things that he really mad at. from the current medication. He used short-acting beta-agonist inhaler when needed. He also take valsartan and amlodipine. He also take vitamin B complex once daily, and lactulose syrup. We also do wound dressing for his bed sore, and he had at-home physical rehabilitation both for his right side weakness and also for breathing exercise. So the main concern is the hemiparesis, post-stroke, and muscle atrophy, the pressure sore, sleep disturbance, and anxiety and depression. He also had financial problem and lack of medical facility nearby, and there's no caretaker around him. So he's a 71-year-old patient with right hemiparesis and atrophy post-ischemic stroke with grade 2 pressure sore on sacral region, COPD, and inadequate family support. So for the discussion point, is he the right candidate for palliative care? And how to address his physical, psychosocial, and financial problem? And how can we provide the overall support system to the patient and his family? Thank you.
Thank you, Dr. Lim. Actually, now the discussion is open to all of you. The first point of discussion is he the right candidate for palliative care? I think all of you can answer this. Anyone please unmute and answer.
Yes, madam.
Yes, please.
Okay.
Anyone?
So all of them are saying yes, that he
Yes.
is perfect candidate for.
Okay, anyone please explain why this particular patient needs palliative care, and when the palliative care should be started, and what are all the things we can do for him?
Yes, ma'am. Yeah. He needs to be addressed for the bed sores pain and for the decreased appetite and also the social support which he is lacking now, no caretaker, and the financial issue also. So definitely he is in need of palliative care.
Yes, Dr. Harita, thank you. Any other points to be added? Yes, Dr. Mahuri. He needs proper counseling and psychosocial support, and needs proper treatment for her source as well. For his source. Yes. Any other points to be added?
He's a person with a chronic problem, chronic disease, without any social backup and financial backup. So that makes him a right person for the palliative care. That is one thing.
Yes, ma'am. Yes.
Actually, he's got a life-limiting disorder. I mean, I don't think it's a life-threatening disorder, and he will require palliative or care even for support after he is like gaining strength and learning to live as normally as possible after he goes on the path to recovery. Because I don't think this is a life-threatening problem as such.
Right. That is true.
So he'll require support even later, like his bed sores, if they are taught to possibly do things which will aid in healing, and slowly you'll have to rehabilitate. So physiotherapy and all will become that should be more important later on.
Smoking cessation should be handled properly. It's very important because smoking will affect his CVA plus his COPD. So his smoking problem needs proper handling. He doesn't want to quit. That is true. He doesn't want to quit, but then we need some measures to handle his smoking problem, which is quite possible. Smoking cessation is one of the very important parts of non-cancer palliative therapy, which we do in our private practice.
Dr. Rutula, we have uh, a point in chat box from Chaitanya. Is this patient need rehabilitation rather than palliative care?
So,
Doctor, we would like to hear from you.
So rehabilitation will form a part of palliative care. Like we would provide rehabilitation along with palliative support that he requires. And also there is not just the physical aspect of it. He has psychosocial issues and financial issues as well. So if you look at it wholly, it comes under the umbrella of palliative medicine and supportive care. But and as Dr. Manjri very rightly said that it's not a life threatening disease at the moment, it is a life limiting illness at the most, and so it will be basically a very long time care for this patient. It's not limited to just few months or few weeks as we usually deal with. It will be a very long term care and kind of a long term needs from the patient side. As for the criteria of patients who fit into palliative care, well, not exactly. It's basically the more, so any life limiting illness is included for referral to palliative medicine. So that includes your stroke and your neurodegenerative ailments and everything. And also the more comorbidities the patient has, the more he or she is likely to benefit from a palliative care referral. So that again adds on to the ailment burden that the patient might have. He can't do everything on his own and needs care 24/7. He needs to be sent to some. Yes, he does require a lot of social support and someone to take care of him 24/7. So a long term care home will be an ideal place for him if there are no caretakers at home. Anything else that might benefit him?
Madam, can I talk?
Sure, please.
Some caretaker, like as you said, I want to express, preferably a family member or else at least somebody else, if they can be along with him and tell him about the pros and cons of his problem, physical problem as well as the smoking problem. Probably he might be comfortable because the children are not able to spare time. So any of the family member or else at least a caretaker who can talk with him about all his problems might soothe him.
Yes, that is true. So, you get a lot of caretakers or even trained nurses who are at home and they take care of the patient at home. So, and if the relatives are reluctant to shift the patient to a care home, it can be done at their own house. But as you rightly said, he requires 24/7 care. So you might have to hire someone for the said care. So again, that will have some financial implications, but even shifting them to a care home will also have some financial implications unless it is completely being funded by the government. So we need to kind of balance out everything.
I would just like to tell that there are some NGOs who are doing home care visit regularly. So they are doing it free of cost, and that the team goes. That doctor, the first visit is doctor and nurse, and the second visit is by the counselor. And first visit takes around 2 hours, and then according to the priority, whether it is high priority, medium priority, or low priority, the homes visits are conducted in 1 week. If it is high priority, the first visit, later the visits are conducted every two times in a week. Then if the priority is medium, then one visit every 15 days. And if the priority is low, then we can see the patient in 1 month once. So there are NGOs which are doing home care visits.
Yes, that is true, but it might not be possible in all the places. Like this is usually concentrated only in the cities, like especially the NGOs and everything who provide home care, and that too free of cost, is mostly concentrated in the cities. So if the patient is not nearby, or not even in the suburbs, it might not be feasible, and not all the cities will have palliative care facilities as well. So there, especially in our country, it's very rudimentary at the moment. We don't have a lot of coverage. Not like, it's mainly been concentrated in Kerala is widespread coverage. But if you leave out Kerala, it's not a lot. Like not even all the major cities have palliative care services. So it becomes very difficult. Not everywhere it's available. But yes, you bring out a very good point to maybe, kind of empowering the NGOs or even the local physicians nearby to provide good palliative care is the way forward, and kind of will increase the coverage and better management of patients with such life limiting situations.
I think we need to have some awareness programs regarding the home care visits.
Yes. Yeah, no, so again, so I think the whole concept of home visits is not just to manage the patient, but also to empower the relatives about proper care of the patient. So we need to kind of educate them regarding his needs and his debility. So it's not that, once the visit is done, thank you ma'am, nothing else has to be done for the next whole week. It's that the relatives or the caretaker who has been appointed has to continue what we have told or we have advised them to do. So its continuity of care would be maintained by uh, the caretaker, and will be re-emphasized on every visits whenever the home visits are done.
Dr. Nim, we would like to hear about the palliative care in Indonesia. Can you please share some words?
Yes, I would like to share about the palliative care here. Here in Indonesia, especially in Bali, where I live, we don't have a lot of palliative care. In fact, it's like one of the lowest palliative care. Not a lot of people knows about palliative care. Even the medical people, like a lot of doctors too, they don't know a lot of palliative care. So we can't send our patient to home care. For the nursing home, because there's also not a lot of nursing home in Bali. In fact, I'm also one of the doctor that do the NGO. I'm part of Red Cross Indonesia, and I do the home care visitation. And this patient, we have a lot of patient like this patient. They don't have any proper financial. They don't have any healthcare, appropriate healthcare. Mostly, a lot of our palliative patient came from lower income family, and because they don't have any insurance, any healthcare insurance, they couldn't get the proper care. So that's why I go far away to India to learn about palliative care.
Thank you for joining.
So I did a home care visit for this patient every week, but that's the hardest part because I also encounter a lot of patients like this where they denied any medication. They don't want to take any because they are fed up with all the medication, and they have this ongoing fear about eating medication. They are afraid to go to hospitals, not only because the financial, because they have this stigma about the hospital. And the thing about life limiting the illness, we take their dignity, like their independence away. So I think that's the most frustrating thing about them. And also, for example, the smoking. He already smoked for at least like half of his life, and suddenly we ban him smoking. It's something very stressful for him. So I think the best thing to do is we reduce it, but we still give him the chance to do smoking, because that's the reason to make him happy. That's the only thing that makes them feel happy about that. And that's, I think, this dilemma here.
Yeah, I actually agree with you regarding the smoking. Maybe you can ask them to reduce the number of cigarettes they smoke, but I don't think it'll be possible to quit smoking at this stage, at least. And so we have kind of similar problems here in India. Like, it's the coverage is not that great, and it's coming up actually. There are a lot of palliative care centers opening up across the country, and there has been even initiative from the government saying that each hospital should have a palliative care department, uh, as at least a running OPD in all the hospitals. So the initiative, it's still to kind of phase out and actually be implemented, but it's on the way. So we just have like a fingers crossed as to like it actually does happen. um so, and again, I think I think it's same across all Asian countries, where we do not like to go to the doctors or like to take medicines and stuff like that. So, and we kind of even stop them halfway just on our own as well. Like, okay, I'm feeling better now, I don't need to take medicine. So it just kind of, just tapers off from there automatically. So that is another thing that we have. And as you rightly said about the dignity, so it's not just not only in life limiting illness. Every time any patient is admitted, even if it's with simple, let's say dengue for that matter, we never kind of say ki, oh, Mr. So and so has dengue. We will be always like, oh, that patient on bed number 10, dengue patient, that way. So we kind of always take away their dignity just by saying ki patient is there. We never kind of call them by their name or never greet them. We'll directly be like, okay, so you're better now? Yeah, just end of the story there only. We don't actually ask them how they're feeling and what they are, going through. So that might be one of the reasons why we are so unpopular amongst all the masses across the places. But yeah, so, and it's not kind of not our fault exactly. Like, we have so many people to see and places to go to. So that might not be our fault completely, but sometimes maybe we need that human touch to just get in their kind of get in their good side, and maybe just they'll actually listen to us properly, be adherent to whatever treatment we are giving, and maybe they will also frankly tell us what is actually happening to them. Like, frankly and truthfully tell us all the symptoms they're suffering through, so that we can manage them better. But again, it takes a lot of patience and a lot of time, so it might not be feasible for everyone, but as much as we can and as empathetically as we can, we should try to do that.
I agree.
Yeah. And I agree with you. Home visits and home assessment is quite difficult, because we don't have half the things that we are used to in the hospital. Like, so if we feel that the patient requires an X-ray, we'll have to kind of send them to to a center where X-rays are available and get it done, and then assess the patient again. So it's not feasible to have a very holistic assessment of the patient at home. But it does make their life a bit easier. So when I was working in Tata, what we would do is we would, we had priority visits, like one that should be visited every week or at least every 10 days. And then, as ma'am said, every 15 days or maybe once a month. But if we felt that no, this patient should come down to the hospital to get a few investigations done, or at least get the blood investigations done at home, because a lot of pathology labs send in their personnel to collect the blood at home as well. So if the blood investigations can be done to get the relative to the hospital, so we can kind of review what is happening with the patient, or if the patient is there, then again do whatever investigations that need to be done at the hospital, and SOS admissions if required. So that is always an option. So always keep that option open. Like never say that, okay, since we're doing home visits, it's just home visits. So it's not always the plan. Like, so you can just, ask them to come into the hospital and get them admitted if required. I'm not saying all the time, if required. And it's always beneficial to have NGO supports. So that is one thing that you could do, especially if you have a lot of financial issues where you practice. So always have NGO support, or even, this sometimes even pharma companies, or even your local industrialists, they have a lot of charity fundings that they do, but we are not aware of it. So, they might be able to provide financial supports for patients of a limited amount. I'm not saying that as and when required, just ask them for money. So maybe a specified amount of money for each patient for a month. So like 1 month, let's say 5,000 rupees per month for one patient, and they cannot ask for that the same amount of money during that month at least, or for 2 months or something like that. You can just specify the amount of time and the amount of money given for that particular amount of time. So that kind of helps. And so we need a good social worker department to kind of have contacts with all these charities and funding agencies and NGOs who will actually provide with all these kind of financial aids. So yeah, that goes a long way. That helped us in Tata a lot. So we had this program where the NGO would provide approximately 1,500 to 2,000 rupees for a month to each patient. And that might not be used up also, like, because we will get the investigations done at the cheapest rate and everything. So that money lasted for a long time for the patient as well. So, but yeah, so that goes a long way. So that kind of helps.
Okay.
Thank you, Dr. Rutula, and thank you, Dr. Nim, for bringing up with this case presentation, and you have done it well. And just for briefing, this palliative care starts with the diagnosis of a life-limiting or life-threatening illness. And coming to this case presentation, we see he was a civil servant and he was working. And he was suddenly affected with the CVA, and all of his life activities has been affected. And he is affected physically, emotionally, he is isolated from social environment, and he cannot go out, and totally his life is affected, and he cannot do anything without the support. And in old age, we all depend on others and the caregivers. Even though there are caretakers, we almost prefer children or our close relatives nearby. So that is also compromised here, and that also are to his emotional deprivation. So emotionally, physically, he is affected, and along with that hemiparesis and all, he has bed sore as well. So he might have pain and everything, and he might have need someone to speak out all those things. And in palliative care, what I have noticed is we should spend more time with the patient. We should hear from the patient what they want to discuss. And regarding the social status and as well as economically also, even though he was working and he has pension, he could not afford the treatments. And so if this is the case with a person who has pension and all, what will be the case with people with low income status? Okay, we can all think about that. So when a patient is coming to us with any disease, in palliative care, we should assess all the aspects, physical, emotional, social, economic, every aspect should be covered. And apart from that, he need rehabilitation. Actually, here there is bed sore. Actually, it has started. When a patient is affected with CVA, we used to hear in Pallium, we used to take measures to prevent the formation of bed sore. That itself should start from, that is why we are telling that palliative care should start from the diagnosis itself. If it has started from the diagnosis itself, the patient might not have this bed sore and all. Why? Because we used to train the caregivers as well as the patient how to take care of them, how to do the positioning, the use of airbed in case of CVA, and the rehabilitation. One of them has asked one question, the role of palliative care and rehabilitation. Both of them should go in hand in hand. Not only the palliative care curative treatment, as well as that all that it should work as a multidisciplinary team. And the doctors also has to talk in between about the patients, what are all the things. If a patient is being referred to palliative care, it is not just the duty of palliative care physician alone. If we need to take any opinion on any other from any other department, we should be free enough to ask doubts as well as. And the doctor also from any other department, if the patient needs more attention to, for example, if the patient needs more attention from neurologist, we will refer back to neurology, and from there they can also take opinion from us. In most of the hospitals, they will have all the team within them itself, but some case all the department may not be available. So I think everything should go in hand in hand, and then only we can give proper care to the patient. And palliative care, and one more point I have to add is regarding sending him to a home care or a care home. That everything we should discuss with the family members as well as the patient. We should hear from the patient what he prefers the most. Sometimes patient may prefers to go to his own home, but sometimes there may not be any caregivers, or he may be living alone. Still, he prefers, sometimes some patients prefers to be at home. Why? Because nobody prefer to be at a place which is totally different from their home settings and all. So everything at any point, we should discuss it with the family as well as with the caregivers. When a patient is unable to communicate, or if his consciousness or GCS is affected, we cannot get it from the patient. And that time we should look for the reliable caregivers, and we should depend on them for, or we should mention what are the possibilities and what are the what all can be done for the patient, and we should give it to the caregivers and the patient to take a decision at any point. And we will see more on this on terminal illness and each system separately in coming sessions, and on that time most of your doubts will be covered. Thank you, doctor. Thank you so much. It's a vast topic, and anyway you have done it well with explaining all the systems. With most of the disease you have covered, and I know it is not very easy to cover everything in one session, but you have done it well. And Dr. Nim also come up with very good case, so that we could bring out all the points in one session itself. I think you all have got so many points from this session. Thank you all, and over to you, Sweetie.
Thank you, Dr. Rutula. Thank you for doing complete justice to the vast topic in a short span of time. Because, of course, when we as coordinators intimate to you that there is also a case to be taken up, your time gets reduced a lot. We do know that, and thank you so much for doing justice. And thank you, Dr. Yuria, for bringing in the concept of palliative care across the country, across the region. And you were one thing to prove that end of the day, it is human. It is the humans that matter. Wherever in the world, it is the humans that matter. And it is the pain that we go through matters a lot. Thank you for bringing out that point. And with a positive hope that in coming days as well, we will get more interesting information to indulge in palliative medicine as volunteers or warriors of palliative medicine. This is Sripriya, along with Dr. Rutula and Dr. Grishma, signing off from the Tips Co-op. And yes, just one more thing. In the feedback form, like we have added a new section, any other comments, wherein you can leave your open comments regarding the faculty, regarding the session contents, or anything you would like to bring to our notice. So till now, it was just the MCQ type feedback form. From today onwards, we have added a section for you. So thank you everyone for joining us. See you in the next session. Bye-bye.
Thank you. Bye.